Hey everybody, Luke here, and I wanted to just put together some information about treating patients with vertigo. Right now, as I'm making the video, we're starting to see a lot more folks for balance and things like that, and we've discovered that a lot of these folks have issues with vertigo and things like that, so BPPV. So I wanted to just start to put together some small incremental chunks of information to help you decide what to do with these folks. And I think the resounding theme is going to be work within your comfort zone, and if you're new to this stuff, grab one of us therapists who's a little more knowledgeable, and just be aware of if you think you know what you're dealing with, then follow kind of the guidelines, and if it doesn't look like something you're comfortable with, just grab someone else. So just background first. So when you're working with someone with vertigo, obviously you're trying to figure out what's causing the vertigo. The most common type of BPPV then is going to be those folks that have a positive Dix-Hallpike test. And when you're just doing their history, you can usually kind of figure it out with their history. So some things to look for. So vertigo is not the same thing as the feeling of unsteadiness or the feeling of lightheadedness or the feeling of dizziness. So when you're doing your subjective and you're taking their history, have them explain when they get the vertigo and what the sensation is like. If they have true vertigo, what they'll say typically is that when I do certain head movements, like tipping the head back or bending the head forward, a quick turn, getting in and out of bed, rolling over in bed, that I get a sudden sensation of vertigo, and ask them to describe what vertigo means to them, and it should be the sensation that their environment is spinning. So if that's the case, you're pretty much kind of thinking of BPPV. Then you're going to proceed to some testing and stuff, which I'll talk to you about later. But again, kind of ferret out what it actually is happening. So, say things like, well, describe it to me when it happens. And they say, well, I just feel kind of unsteady all day long, something like that. You say, well, okay, well, when you do certain motions, do you get the sensation of spinning? And oftentimes it's pretty strong and uncomfortable. And if they don't have that, you're not typically tending to think vertigo. Doesn't mean you're not going to still test them for vertigo, but just kind of be aware of that as you're questioning them. The other things to watch out for are things like orthostatic hypotension. So if they just feel kind of lightheaded when they try to stand up too quickly, typically that's not vertigo. They might get a little bit of the sensation of moving, but not typically. It's just typically more lightheadedness. So keep that in mind. The other thing with the history then is that typically if they have positional vertigo, which again is the BPPV, benign paroxysmal positional vertigo, typically it's going to be sudden and strong, and it'll last typically about 30 seconds or so. Sometimes a little longer, sometimes shorter. So again, when you're taking their history, just keep all those things in mind before you start looking at things like the Dix-Hallpike and stuff like that. So that's the quick introductory one. You also want to rule out things like, did they have a stroke? The most common one to rule out when you're doing the Dix-Hallpike 2 is like the vertebral artery compression. So you want to rule out some of these more kind of sinister medical things, which I'll show you in a different video. So again, just kind of be on the lookout for what it should look like and sound like, and then you can go into some more of the testing. So I'll get to some more videos on how to test for things like Dix-Hallpike and the vertebral artery test and stuff like that. So thanks.